Dear colleagues, welcome to day 2 of the EMAS joint webinar. My name is Professor Petra Stute and I'm the president of the European Menopause and Andropause Society. I'm a gynecologist and I'm working at the University Clinic in Bern in Switzerland. And my focus is on gynecological endocrinology and menopause and reproductive medicine. So before we begin, I would like to thank all of you for the strong engagement we saw yesterday. The level of participation and discussion clearly reflects the need for this kind of multidisciplinary exchange in menopause care. So day 1 highlighted several important points. Menopausal symptoms extend beyond vasomotor complaints and may begin while women are still menstruating. Diabetes is not a contraindication to menopausal hormone therapy and may even offer metabolic benefits. We also discussed how MHT can be considered after certain gynecological cancers, depending on pathology and stage, and its role in preventing osteoporosis in peri- and early postmenopausal women. Today, we build on that foundation, moving into Uro-gynaecology, with the same focus on real cases and collaborative discussion. Thank you for being with us. I will now hand over to my co-chair, Dr. İpek Özçivit Erkan.
Many thanks, Professor Stute. It's a truly special honor to be co-chairing this joint webinar with you, IMAS President. This is the second day of our joint webinar with Esa, Entok, and Watok, and I'm genuinely proud to be here as a member of IMAS Early Career Working Group. I'm Dr. İpek Betül Özçivit Erkan from Istanbul, Turkey. I'm a young obstetrician and gynecologist. I completed my PhD in female pelvic anatomy. I'm currently working in Acıbadem Health Group, and my research interests are menopause and uro-gynecology. This is our very first activity as an early career working group, and it's incredibly meaningful for us to see such a high engagement. Yesterday, it was an inspiring start to this series. Over 1,200 participants, who were 600 alive online, and we received a lot of questions, which reflects the enormous interest in these topics, especially among early career professionals. So today we also have a very special program focusing on urogynecology, as Professor Stute mentioned. We will have 4 expert talks delivered by leading specialists and society representatives, followed by 2 multidisciplinary case discussions where all speakers, moderators, and co-chairs will come together to share their insights and perspectives. Before we head off, I would like to summarize a few points. After each presentation, there will be a 5-minute Q&A session. I sincerely encourage you to share your thoughts via the chat. However, submit your questions through the Q&A area so that the speakers can address them efficiently. We will do our best to answer as many questions as possible live, but for that remain, the speakers will kindly provide their answers in the Q&A box after their presentations. During the multidisciplinary case discussions, there will be interactive polls, so stay engaged for that as well. It will be a unique opportunity to share your perspective. And lastly, I would also like to emphasize that this joint webinar series has been accredited with 4 European CME credits, and attendees will earn their points based on the time they spent in the live session. Having said that, it's my great pleasure to introduce our first speaker today, Professor Tamer Erel, who will present menopause, urogenital aging, and pelvic floor health. Professor Erel has been my mentor for more than 10 years, so it's an honor to present him here. He is a renowned specialist and professor in obstetrics and gynecology with expertise in menopause, IVF, and gynecological laser treatments. He is currently the vice president of EMAS, And he is working at Istanbul University Cerrahpaşa, head of Uro-gynaecology division. I would like to ask Professor Erel to take the virtual stage and share his expertise with us. Please.
Thank you, İpek, for your nice presentation introduction for me. So I would like to share my presentation. Yeah. Okay. Okay. My topic is menopause, urogenital aging, and pelvic floor health. Healthy aging includes comfort, confidence, and control. Menopause and aging are related, but their effects on tissue can differ. In this context, one of these tissue is the urogenital tissue and pelvic floor muscles. In 2014, the International Society for the Study of Women's Sexual Health and the North American Menopause Society agreed that the genitourinary syndrome of menopause is a more inclusive and accurate term to describe the conglomeration of external genital, urological, and sexual symptoms and signs caused by hyperestrogenism during menopause. And the definition GSM also describe its limitation boundaries. One of these boundaries is this syndrome is depend upon the estrogen deficiency. Another is the tissues affected by this syndrome. These are the vagina, vulva, urethra, and bladder, the anterior compartment of the pelvic floor. And it is now evident that the term GSM does not encompass all changes related with the pelvic structures. GSM exclude pelvic floor muscles and endopelvic fascia. Furthermore, GSM prioritizes the changes related with the estrogen deficiency, but not androgen deficiency after menopause, ignoring the changes associated with aging. And estrogen and androgen receptors are expressed in epithelial cells, connective tissues, stromal cells, striated muscle fibers, in the urinary, genitourinary tract, lower genitourinary tract, and the pelvic floor structures as shown here. And estrogen, as all we know, proliferates the vaginal superficial cells, induce glucose storage in these cells, stimulates the production of collagen and elastin fibers in the lamina propria. It increases the angiogenesis and blood flow around the vagina. Also, it maintains lactobacilli dominance and it lowers vaginal pH and acidifies the secretion. An estrogen deficiency after menopause causes thin and dry of the vaginal mucosa, decreased elasticity, decreased blood flow, increased vaginal pH, and in turn, alteration in the vaginal microbiome. And similarly, estrogen deficiency can lead to reduced uroepithelial thickness, collagen and elastin fibers in the lower urinary tract, and reduced vascularization, and it induces its deficiency induces the hyperresponsiveness, both autonomic and sensory neuron innervation and calcium activated potassium channels. And these changes lead to urethral shortening, decreased urethral sphincter contractility, reduced urethral closure pressure, and decline in bladder compliance and capacity, and increased involuntary detrusor overactivity. As shown in the previous slide, androgen receptors are found in the urogenital tissue and the pelvic floor muscle and the pelvic fascia and even in anal sphincter muscle. And androgen can exert their effects either through the androgen receptors, which are found in the vesicle, clitoris, urethra, and so on, or through the estrogen receptors after being converted to estrogen or estrogenic-like substances by activation of locally expressed enzyme in these tissues, which we call it the intracrine pathways. And with decline in androgen levels after menopause, several changes may occur in the vaginal tissue, like thinning, epithelial thinning, decrease in glycogen, decreased vascularization, lubrication. At the level of urethra and bladder, androgen deficiency can cause decreased urethral closure pressure and vascularization. And there are some sexual, they may cause some sexual dysfunction. And also, from the perspective of pelvic floor muscle, the anabolic effects of androgens are particularly important. And in the pelvic fascia, there is a reduction in collagen synthesis, increase in collagen degradation, decreased fibroblast activity, and all these change leads to loss of dynamic support for pelvic organs. Impact of androgen and estrogen deficiency after menopause and aging on vulvar health is also profound. And here you can see all changes, the structural and cellular changes by aging and the hormonal and molecular changes affected by the hormonal deficiency, androgen and estrogen deficiency. And consequently, it may lead to loss of firmness and volume of the vulva, increased skin fragility, slower wound healing, marked epithelial thinning, reduced elasticity, and altered microbiome. And pelvic floor is another issue and a complex structure of muscles and connective tissue that supports the pelvic organs. The levator ani muscles and the pelvic fascia work together to provide a hammock-like support to the pelvic organs. And their function is to facilitate the continence by a coordinated lifting and closure mechanism. And menopause, the estrogen deficiency after menopause, concomitant with the age-related changes, may exacerbate the pelvic floor dysfunction. By aging, there are some alterations in connective tissue remodeling. These include reduced type 1 collagen, increased type 3 collagen, and so on. And the cross-linking of collagen fibers can be disrupted by chronic inflammation as well. And on the other hand, it may be disrupted by reaction with glucose, glycation of the fibers are important. These changes lead to reduced ability to accommodate the pressure or stretch and reduce urethral closure pressure and increase urethral mobility, resulting in stress urinary incontinence. And also microvascular aging is important. These changes include the reduced capillary density, reduced endothelial nitric oxide production, and so on. Neural changes, neural aging is important for bladder and urethral, and these changes include the loss of afferent sensory fibers, reduced bladder sensation accuracy, delayed urge perception, poor coordination between bladder and outlet. These changes contribute to urgency and incomplete emptying the bladder. On the other hand, motor neuron loss, denervation, and impaired neuromuscular coordination in the pelvic floor muscle result in reduced endurance under the repetitive load, failure to contract before the intra-abdominal pressure rises, and increased risk of stress urinary incontinence and pelvic organ prolapse. Smooth muscle cell loss and fibrotic tissue replacement resulted in reduced contractile responsiveness and increased residual urine in the bladder. And in this context, the sarcopenia for pelvic floor muscles and the muscle connected tissue interface degeneration important. And pelvic floor muscle like other skeletal muscle, experience a decline in mass and strength due to the sarcopenia, and especially there's a significant loss and atrophy of type 2 muscle fibers. And moreover, the weight gain, central adiposity, and conditions such as chronic coughing, constipation, diabetes, associated neuropathy further impair the pelvic floor muscle function, thereby raising the risk of stress, urinary incontinence, and prolapse. And muscle connective tissue interface degeneration occurs, fascia becomes stiffness, and the force transmission efficiency decreases. And there are some guidelines. This is one of the recent one. Is published in 2025. This recommendation belongs to American Urology Association. But what is important for us, the symptoms and the signs of genitourinary syndrome of menopause is important, and the clinician should recognize these symptoms when she or he takes the anamnesis from his or her patients, or should recognize the signs during the examination. And the other one is published in this year, 2026, which is these recommendations from the Fifth International Consultation of Sexual Medicine. Here are the the physician should take into account these GSM signs during the physical examination, and also should pay attention these GSM symptoms at the clinical interview. The pelvic floor deficiency deficiency leads to pelvic floor dysfunction. In other words, the pelvic floor dysfunction refers to a broad constellation of symptoms and anatomic changes related to abnormal functions of the pelvic floor muscles and the pelvic fascia. The clinical aspects of pelvic floor dysfunction can be urologic, gynecology, or colorectal, and are often interrelated. And the assessment tools for pelvic floor dysfunction includes the anamnesis, examination, additional tests. If necessary, if there is an indication, uroflowmetry, radiologic studies, and cystoscopy can be performed. But the anamnesis and examination have vital importance. Therefore, I would like to go in details for the anamnesis. It is essential to inquire about the specific prolapse-related symptoms such as pelvic heaviness, vaginal bulging, vaginal discomfort, and low back pain. And it is crucial to identify comorbid conditions that may contribute to urinary incontinence, including lower urinary tract issues, neurologic conditions, systemic factors such as diabetes, heart failure, and sleep apnea, and functional and behavioral contributors, lifestyle factors such as smoking, coughing, chronic cough. These are important. A true medication review should be conducted, and certain drugs may affect the bladder functions, and evaluation should include a brief sexual history. On the other hand, the pregnancy, delivery history, genetic family predisposition, obesity are the important risk factors for pelvic floor dysfunction. And the physical examination should include the assessment of general health, BMI, and neurologic function. The neurologic function, the bulbocavernosus reflex shows the intact reflective arc in terms of the sensory and motor functions in the perineal area. And the vulvovaginal health can be assessed by performing the vulvar health index, vaginal health index, vaginal pH, and so on. The descent of anterior apical and posterior vaginal wall should be determined by using the PAPQ system. And if you need urine analysis and all other additional tests can be done. And the clinical consequences of menopause and aging on urogenital and pelvic floor health can be summarized like that. Lichen sclerosis at atropicus, vulvodynia, vestibulodynia in the vulvar area, and the clinical consequences can be atrophic vaginitis in the vagina, and recurrent urinary tract infection and urge incontinence in the lower urinary tract, and dyspareunia, sexual pain, and decreased desire, or other sexual dysfunction disorders can be seen as a clinical consequences, and the pelvic organ prolapse, stress urinary incontinence, and anal incontinence. The anal incontinence is very important, and it is usually ignored during the exam and during the anamnesis. So I would like to touch upon this issue. And the diagnostic algorithm should include the genitourinary syndrome of menopause and pelvic floor deficiency. After carefully taken anamnesis and exam, the diagnosis can be overlapped and should include both pathways. The last few words regarding the managing of urogenital aging, GSM, and pelvic floor dysfunction. And British Menopause Society recently released a recommendation for the GSM, and also the International Continence Society released very brief recommendations in the treatment in the management of pelvic floor dysfunction. And here you can see, and of course the speaker after me will go in details, so I would like to stop my talking here, and thank you for your attention.
Thank you so much, Professor Erel, for your outstanding talk and for sharing your unique perspective on urogenital aging. It encouraged us to integrate different aspects of pelvic floor health to our daily practice. So I would now like to open the floor to questions and start from the questions in the Q&A box. One of our participants asked how to treat impact on urogenital tissue by reduction of collagen. Can collagen supplement help? She said.
As far as I know, the collagen supplements, there is no study where the collagen supplements can help the urogenital, that the collagen supplements can increase increases the vulva and the vaginal volume and size. So in my opinion, there's no solid evidence to use the collagen supplements to increase the vulvar and vaginal volume. So I would say that.
Thank you for your response. The next question is about vaginal estrogen. She's from Turkey who asked the question. She said there is no estradiol cream in Turkey, but only estriol. So in this international platform, she asked about which countries have estradiol cream for vagina, or what do you prefer to use in GSM treatments locally?
In Turkey, we have the estradiol tablets, and we have the estriol cream. So I personally used this medication in the treatment of atrophic vaginitis. But maybe Petra may answer this question in the European aspect.
So you're wondering if what kind of estrogen we are using in.
Yeah,
We have,
that's the question.
so we have estradiol as tablets and 10 microgram estradiol tablets, but they are not that frequently used because we have so many more estriol products. So we have cream, suppositories, gel, and in Germany, for example, there's also an estriol that's actually an estradiol ring available. But I think the majority of women are probably treated with estriol products. And we have more dosages. That's probably also important. So for estriol, we have like standard dose vaginal estriol, we have low dose, and we have ultra low dose vaginal estriol, whereas for estradiol tablets, we only have ultra low dose tablets, at least in Switzerland.
We don't have such a variety in Turkey, Petra. So you are lucky, and the patients also.
I was actually wondering about the question that popped up about vaginal testosterone, because I also wanted to ask you this, because
Yeah.
very rarely I prescribe vaginal testosterone, because I once found some studies from Brazil using vaginal testosterone. And are you using this too or never? It's a
No,
compounded thing then, of course.
we don't have the vaginal testosterone in Turkey, but um, uh, according to some studies, and even what made me surprised is the a randomized testosterone randomized study clearly showed that the vaginal testosterone improves the um, stress urinary incontinence over placebo. So, but it's very little and very impactful study. So the number is quite small, but
Mhm.
um, testosterone, in my opinion, should be given to women with hyposexual desire disorder. But beyond this indication, they may help to the improvement in pelvic floor muscles and the pelvic fascia.
Mhm.
They may, but in animal studies, there are some studies showing the improvement, but there's no study in human beings, in women so far.
Thank you for Professor Aral and Professor Stute for the nice discussion. Due to time restriction, we need to move. So the questions I would like to ask Professor Aral to kindly answer the
Sure,
question in the Q&A box. Thank you.
sure.
Thank you.
So now you
And
have a job for the next minute.
I'm delighted to hand over the microphone to you, Professor Stute, for the
Thank you.
next presentation.
Okay, so it's a great pleasure for me to introduce to you the next speaker and the next title of the presentation. So the title is Genitourinary Syndrome of Menopause, what it is and how to manage it. And the presentation will be given by Dr. Sofia Tsipakido. I hope that I pronounce it correctly. She's a clinical research fellow in minimally invasive gynecological surgery, and she's the NTOC president, and she's a PhD candidate in Uro-gynaecology. So please share your slides and start, and we are very much looking forward to your presentation.
Hello, everyone, and I think that now you are seeing my slides. Thank you very much for EMAS and EAIES for the kind invitation. We're very delighted as ENTOC, as European Network of Trainees and WODOC, to collaborate with you, and we cannot wait what the future holds after this success. Thank you very much for the kind invitation, and let me speak about GSM. After the delightful presentation of Professor Emel, I don't know what I can say more on that, but I will try. So, what it is and how to manage it. As is already said, it's a set of signs and symptoms from reduced estrogen and other sex steroids affecting the labia, clitoris, vagina, urethra, and bladder. It replaced the previous terminology as VVA in order to underline the multitude of genital, sexual, and urinary symptoms associated with the anatomical and functional changes of the vulvovaginal tissues occurring with menopause and aging, as already said. 2020 NAM's position statement highlights that GSM affects from 27 up to 84% of postmenopausal women, often causing significant impairment in health, sexual, and quality of life. Other study, like Revive study, a fair estimation of the interviewed women during our clinical consultations show that 40 to 60% of them report GSM. Bothersome. Genital symptoms are often the earliest and most noticeable manifestations of GSM, yet they may be underreported unless specifically discussed by the physicians. As you can see, the prevalence, there is more than 55% of vaginal dryness, and also you can see from the European Revive survey from a pool of 32,000 of women, more than 3,800 women reported related with the GSM symptomatology. Why women underestimate or they not report their symptoms, GSM related symptoms? Because they feel embarrassed on reporting symptoms, because sometimes the symptoms are not warrant enough to provoke a discussion, or their own personal belief that this is a natural path of aging. So, what we can do as physicians? A proactive attitude by us is essential for this condition. So, women affected by VVA and GSM can understand that happens to them, and they can seek medical help and receive treatment. Underdiagnosis and undertreatment lead to chronicity and disease progression. So, this is a very severe impact on women's quality of health. Identifying GSM not only isolates complaints, but as a syndrome supports the holistic care, because early treatment can prevent progression and improve comfort and well-being, while opening discussion also for other matters as sexual and urinary health. What is the vaginal atrophy? As you can see, the transition from premenopause age to postmenopause age, you can see that the superficial cells decreasing from 15 to 1%, the parabasal cells from 5% increase to 40%. So it changes. What you can see as clinicians during our physical examination. The vaginal atrophy is associated with pale, dry, shiny vulval tissue, the loss of adipose tissue in the labia. Also, you can see the prepuce and the clitoris in the image in B that are pale and reduced in size. The introitus can be narrowed and friable, and also you can see that at the vaginal walls, lack of rug and maybe pale, or there are also exist petechia. The most common patient-reported symptoms are dryness, itching, irritation, burning, dyspareunia. Also, they can report or they can complain about urgency, increased frequency, nocturia, dysuria, incontinence, recurrent UTI. And we can also look for all the other psychosocial signs that can affect our patients. Dyspareunia and sexual pain is a cardinal symptom of GSM, along with decreased or delayed orgasm, decreased arousal and lubrication, and secondary decrease of sexual desire, which overall may cause poor sexual satisfaction. As you can see, there have been some recommendation of GSM diagnosis using validated scales and questionnaires, or using our physical examination and clinical tools like the vaginal pH, the maturation index, or the physical examination and visual assessment. Another simple checklist proposed in 2019, it goes from the subjective dryness, dyspareunia or other dysfunction, or urogenital pathologies, the pH in order to check the microbiota and rule out any other infections, and the objective signs as pallor, rake, or petechia. Also, we can use some scales from 0 to 3 severe, the objective signs about elasticity, the vaginal rags, the fluid secretion, the thickness, the moisture, and the color of our tissues, and the subjective ones from 0 to 4, like dryness, dyspareunia, irritation, bleeding, etc. An example of some validated questionnaires is the Vaginal Health Index score that evaluating 5 parameters: the vaginal elasticity, secretions, pH, the mucus, and the vaginal hydration. And then we are evaluating the final score. It's from 5 to 25, and lower scores correspond to greater GSM. In the Vulva Health Index, for example, it evaluates the labia, the urethra, the clitoris, the introitus, as well the elasticity and pain during the intercourse, though that scores ranges from 0 to 24, and any 0 above 8, any score, sorry, or any value that is 3, like severe in any of these categories, so a GSM is suggested. Before putting the diagnosis of GSM, we have to rule out or evaluate other different pathologies like lichen, hyperkeratosis, contact dermatitis, vine, vulvar carcinoma, or Paget disease of the vulva. Now the treatment algorithm. We have to consider and to have to discuss with our patients which symptom is the most bothersome, vulvovaginal, urinary, or sexual. And we have different options, as you can see. The SIGO, the Spanish Society, also has published an article about how we can consider the treatment according to the severity, if it's mild, moderate, or severe. So, as clinicians, we should engage with our patients a shared decision-making management plan, taking into consideration the latest evidence, but at the same time, a very good counseling and respecting the patient's expert values, preferences, and above all, to set common goals for our treatment regarding the GSM care. So, what we can counsel our patients as treatment: physical and lifestyle interventions. Regular sexual activity has demonstrated that increase the blood flow to the tissue, enhance the lubrication, and maintain the vaginal elasticity and depth. Physical therapy, pelvic floor physical therapy, and regular exercise as Kegels or any other kind of pelvic floor rehabilitation improve the muscle strength, reduce the tension, and improve also the bladder function. Smoking cessation has correlated with a positive impact on vaginal epithelium, causing decreased atrophy and stopping also the progression of the syndrome. And also we have to suggest and promote proper hygiene habits like avoiding any irritants, perfumes, and hard soaps in the area in order to minimize the irritation. About the before proposing the moisturizers and the lubricants, we have to think and to have to know as physicians what is the ideal osmolality threshold in order, because there are a lot of different brands and products in the market. So we have to consider something that osmolality is close to 380 as proposed and recommended by the WHO, and the pH in order to respect the normal values between 3.8 to 4.5. There are so many different vaginal lubricants and moisturizers depending on where do you live, in which country, which continent. So I cannot say so many about the brand names because I already discussed, for example, the vaginal testosterone is not also provided in Greece, where I'm located. But what we can see about the lubricants and moisturizers, like what they do, they hydrate the vaginal tissue in order to minimize the irritation and the infection. They try to lubricate the tissues without causing any further irritation, and they're trying to maintain the vaginal pH as low as possible. and they're trying to help. They can be also used during the painful intercourse, and also for any kind of expressing pain during the day life, during after going to the toilet, or during their walking or being stood up. So we have to recommend all those. Few words about the local hormone therapy, the estrogens. As you can see, all over the body there are different estrogen receptors, so we have to be fully informed about the personal anamnesis and before recommend any kind of HRT. But except the local hormone therapy and the positive impact on our GSM, I just needed to make a comment about the recurrent UTIs. That you can see that increases with the age up to 15 at the age of 6 up to 20 after the age of 65. And also IMAS has published two different articles about it, and you can see that the local hormone therapy with local low dose of estrogens can also be helpful for our patients complaining about recurrent UTIs. There are different forms of local vaginal estrogens, as already commented, like creams, tablets, rings, gels, and already mentioned the latest NHS patient information publication about vaginal estrogen. You can see some different brand names. And the thing that I would like to state is about that it's now recommended about how long to use it for. We can take local HRT with vaginal estrogens between 2 to 5 years to relieve symptoms that maybe it can be longer, but now we can have also a timeline for our counseling. Like we can use it, it needs at least 3 months to work fully, but we can counsel our patients that they can use it for the next 2 up to 5 years. Also, there are other several recommendations. For example, the Spanish Society has said that it should be started as soon as possible and should be maintained long term in order to decrease any negative impact. The AM says that we should be cautious about the minimum dose necessary to achieve our objective goal for the GSM care, and IMAS recognize and mention that there are no pre-established limits on the duration of local hormonal therapy. Now, some few words about the concerns or dislikes from patient reported about the lubricants and moisturizers, that the messiness and the vagina and that the effect the vagina is not restored to natural up to 40%. About the vaginal estrogen concerns is that the safety, as already mentioned, there is a lot of evidence now that it's safe enough for our patients, and we should also it should be also included in our counseling. And about never used any kind of these things is that the symptoms not bothersome enough, or that it's something like assume that the symptoms will not go away. About a specific category, our breast cancer survivor patients, that you can see that we have to educate our breast cancer survivor that they can receive a GSM care, and also about all the available treatment options. As you can see, it depends from the estrogen receptor type, cancer type. If it's negative, we can use lubricant moisturizer or local hormone treatment. If it's positive, and it's under aromatase inhibitor or tamoxifen treatment, we can start by the non-hormonal treatment. And if there is no improvement, we should reassess and we should counsel about local hormone treatment in coordination with the treating oncological team. And if our patient is estrogen receptor positive and she has already completed the adjuvant therapy, also we have the same pathway, but also we can consider the ospemifene, the oral serum, oral available treatment option, if locally approved, also in coordination with the oncological team. As physicians, we should inform our patients there is absence of evidence linking local low dose vaginal estrogens to the development of breast cancer. And for patients with the GSM who have a personal history of breast cancer, we should recommend local low-dose vaginal estrogens, but always respecting and in context of MDT shared decision-making with the treating oncologist, ourselves, endocrinologists, physiotherapists, and our patients' beliefs and personal goals. As you can see, from 2025, a practical clinical approach study that was published, that there is the concerns about the possible systemic abortion, but it's unknown the association between systemic abortion and recurrence of risk of or stimulation of breast cancer cells. So in lack of data, we cannot cancel our patients negatively for the use, as we don't know. So for me, as already some studies have already proved their efficacy and the symptom-related improvement, is the most effective way for treat GSM in this category of patients. So we should concern and to include it in our counseling. Few words about ospemifene. I'm not used to it because it's not yet circulated in Greece. It's an oral non-hormonal selective estrogen receptor modulator. It is approved for the treatment of GSM, especially for our patients complaining for dyspareunia or vaginal dryness. The dose is 60 mg orally once daily after food, and we should wait 3 months in order to see symptom improvement assessment. There are different, even it's not estrogenic, there are produces different agonist or antagonist effect depending on the tissue. In vagina and endometrial, it's agonist effect, and in breast, it's antagonist effects that blocks estrogen-dependent proliferation, so doesn't destimulate further the breast tissue cells. And the latest category, except the androgens, the vaginal, local vaginal estrogens, that also we can be include in our counseling, but still it's very limited. The market circulation around Europe and I think the world is the energy-based treatments like CO, like ER-YAG or radiofrequency, that you can see that the effect, the treatment effect that it has in the tissue. And from the day 1 to day 15, there are different principles. For example, in YAC, is that the heat waves reaching the vaginal mucosa and the collagen fiber is shorter and thicker. So we have a remodeling, sorry. And as we can see that causes the laser category minor wounds in the epithelium and lamina propria, activate the fibroblasts and increasing the collagen productions, so it provokes vaginal tissue regeneration. The radiofrequency, it's control electromagnetic waves in order to produce heat in our tissue, and also produces and increases the collagen production, reorganizes the fibers, and also provokes tissue remodeling. There are the data till now, the first initial studies were very promising, but after I think 2019, the data are inconclusive regarding the efficacy. There is an identified optimal number of treatment cycles in order to see to cancel our treatments and the need of retreatment. How long we should redo the treatment. And also, it's not yet clear or reported the improvement of our GSM symptoms, comparing the treatment and the placebo, the sum. So we need further studies in order to be more, let's say, optimistic or positive on energy-based treatments for our GSM. And this is from me, and thank you again for the invitation, and happy to answer any question.
Thank you very much, Sophia, for this wonderful overview about all the different treatment options. And the colleagues have been very busy with answering questions during your presentation, but there are some left. And in the interest of time, I will only give you one question. And then maybe you can also help with answering the rest of the questions during the next presentation. Okay, so I will ask the question, which I'm also very curious about. Do you know what's the current situation of ospemifene in Europe? There was no specific room for the lecturer's experience on this product. And I must say, I would also not be able to give any own experience because it's not approved in Switzerland. Do you know in which countries it's actually used?
In UK and Italy, to my knowledge, I know that there is the ospemifene and ospeni, and something like that, the brand name. From the studies that I have read, it's very promising. It's oral, it's easy, and also more patient discipline, let's say, because it's oral and there is no this vaginal messiness, to be honest. And also the symptom related assessment is very promising that our patients feel very well taking this treatment. I don't have any personal experience in order to be clinically evaluate ospemifene. I know that in Italy it's very widely used and also in UK.
Okay,
And
but that's really interesting because sometimes I order medication from abroad, from other countries in Europe, and now that I know that it's available in Italy, I know where to order it. So that's
yes,
great.
yeah.
Thank you very much, Sophia. So I suggest, as we are a little bit behind the time, I hand over to Ipek, and she's going to introduce to you the next speaker.
Thank you, Professor Stute and Dr. Sofia, for the exceptional talk. It's now my pleasure to introduce our next speaker, Dr. Hasmik Baregamyan, MD, PhD. Her presentation will focus on managing abnormal uterine bleeding in women on menopausal hormone therapy. Dr. Baragamyan is a lecturer in the Department of Obstetrics and Gynecology at Yerevan State Medical University after Miktar Heratsi, Armenia, and an obstetrician and gynecologist at Beglerian Medical Center in Yerevan. She is specialized in gynecological endocrinology and menopause care. Dr. Hasmik, the floor is yours.
Thank you for your nice introduction, dear Epak. Good evening, dear colleagues. It's a great privilege to speak today in the webinar series organized by European Menopause and Andropause Society. Let me share my screen. Okay. Today, we will discuss one of the most important, most common, and often anxiety clinical dilemmas, how to manage abnormal uterine bleeding in women using menopause hormone therapy. This situation is more than just a diagnostic issue. It requires a careful balance between oncologic vigilance and preservation of vasomotor symptoms, quality of life, and because for many women, menopause hormone therapy remains the most effective treatment for vasomotor symptoms and other menopause-related conditions. During this lecture, I will focus on three practical aspects: evidence-based thresholds of investigations, modern ultrasound interpretation, and a clear management algorithm, all align with guidance from European Menopause and Andropause Society, International Menopause Society, International Society of Ultrasound in Obstetrics and Gynecology. Learning objectives. By the end of this lecture, participants will be able to know this first, distinguish expected bleeding pattern from pathological bleeding in women using menopause hormone treatment. apply a structured and guideline-based diagnostic approach when evaluating abnormal uterine bleeding in these patients, interpret ultrasound findings more comprehensively, looking beyond endometrial thickness and incorporating endometrial morphology and Doppler assessment. And finally, optimize menopause hormone treatment regimes rather than discontinuing treatment automatically when bleeding occurs. Studies suggest that unscheduled bleeding may occur in up to 38% of women using sequential regimes and up to 41% of women using continuous combined regimes, particularly during the first months of treatment. Although most bleeding episodes are benign, bleeding is one of the most common reasons women discontinuing treatment. Unscheduled abnormal uterine bleeding not only affects quality of life, but also raises oncological concerns about endometrial cancer. Fortunately, the absolute risk remains relatively low, generally around 1 to 2% in women using continuous combined menopause hormone treatment. However, fear of malignancy often leads to premature discontinuation of treatment. This creates two clinical challenges. On one hand, over investigating may increase patient anxiety, healthcare costs, and unnecessary procedures. On the other hand, under investigating may delay diagnosis of significant pathology. Therefore, the clinical goal is clear: to protect endometrium while maintaining effective symptom control. The first and most important principle is that in scheduled bleeding during menopause hormone treatment should be automatically be equated with spontaneous postmenopause bleeding. Spontaneous postmenopause bleeding is defined as bleeding that occurs after more than 12 months of persistent amenorrhea, and it must always be considered abnormal until proven otherwise. In women using menopause hormone treatment is often related to the hormonal regimes itself and may represent physiological responses to therapy rather than pathology. Several factors influence bleeding patterns during therapy are the type of regimen, whether continuous combined or sequential, the duration of therapy, and whether progestogen exposure is adequate to protect the endometrium. Understanding these factors is essential before deciding whether further investigation is required. Let us now consider how to distinguish expected bleeding patterns from abnormal uterine bleeding during menopause hormone treatment. In a continuous combined menopause hormone treatment, the goal is progressive endometrial atrophy and eventual amenorrhea. So during the first 3 to 6 months to treatment, irregular spotting and light bleeding is relatively common and usually reflects endometrial adjustment, adaptation to continuous combined hormonal therapy. However, investigation becomes necessary when bleeding persists beyond 6 months, bleeding occurs after a period of established amenorrhea, or bleeding becomes progressively heavier. In contrast with sequential, bleeding is considered abnormal when it occurs outside the progestogen phase, when it is unnecessary, heavy, or prolonged, or when intermenstrual bleeding occurs. Recognizing these patterns helps clinicians determine which patients require investigation and which may simply require reassessment or adjustment of therapy. Risk stratification is an essential step when evaluating abnormal bleeding in women using MHT. The major risk factors for endometrial cancer includes severe obesity, hereditary cancer syndrome such as Lynch syndrome or Cowden syndrome, a history of chronic anovulation such as PCOS, prolonged exposure to unopposed estrogen in women with an intact uterus, inadequate progestogen protection during therapy. Minor risk factors include moderate obesity, metabolic syndrome and insulin resistance, diabetes, and long-term use of sequential hormone therapy beyond 5 years after menopause. Use of selective estrogen receptor modulators such as tamoxifen. Here, you can see a diagnostic algorithm in patients taking tamoxifen. In those without bleeding, abnormal uterine bleeding, ultrasonography is not indicated. In those presenting with bleeding, ultrasonography helps guide the clinicians in triaging patients with required follow-up, office sampling, or hysteroscopy. When evaluating abnormal uterine bleeding during menopause hormone treatment, a structured diagnostic approach is essential to avoiding unnecessary invasive procedures. The first step is clinical assessment. This includes detailed history focusing on the bleeding pattern. The second step is physical examination. A speculum examination helps identify possible local causes of bleeding, such as cervical lesion, polyps, or vaginal atrophy. A bimanual examination evaluates uterine size and adnexal masses. At this stage, clinicians should also ensure that cervical screening is up to date with a pap smear. The third step is transvaginal ultrasound. An ultrasound examination is performed first to search for lesions in bladder, rectum, ovaries, cervix, or myometrium, and sampling is performed and evaluate the endometrium. Finally, when indicated, endometrial sampling is performed to obtain a histological confirmation. According to the 2026 consensus, endometrial thickness alone is not sufficient. Comprehensive assessment includes endometrial thickness, echogenicity, endometrial midline appearance, the endometrio-myometrial junction, and Doppler vascularity. This systemic approach follows recommendations from the International Endometrial Tumor Analysis Group. However, several ultrasound features should raise suspicious for malignancy. Heterogeneous endometrium, an irregular endometrio-myometrial junction, multiple or branches vessels on Doppler examination, or focal masses with the cavity. The key message is clear. A thin endometrium does not completely exclude pathology if morphology is abnormal. This slide summarizes a practical clinical algorithm for the management of unscheduled bleeding in women using menopause hormone treatment. The first step is always to assess the clinical context. The next step is transvaginal ultrasound. Based on ultrasound findings, patients can generally be divided into two clinical groups. The first group includes women with low risk ultrasound features. These findings include an endometrial thickness of 4 millimeters or less in women using menopause hormone therapy, combined hormone therapy, 7 millimeters or less in women using sequential regimes, homogeneous endometrium, a regular endometrial junction, and minimal vascularity on Doppler examination. In this situation, the risk of significant pathology is low. Therefore, the recommended approach is conservative management, which includes observation for up to 6 months and optimizing of the MHT regimen. Reassessment is recommended if bleeding persists. Second group includes women with suspicious ultrasound features. This includes endometrial thickness greater than 4 millimeters in continuous combined regimes, greater than 7 millimeters in sequential, a heterogeneous endometrium ecotexture, and irregular endomyometrial junction, the presence of local lesions such as polyp or abnormal Doppler vascularity. Histological results then guide further management in this group. If benign conditions are indicated, treatment should focus on addressing the structure cause and optimizing the hormone therapy regimes. However, if premalignant and malignant pathology is detected, such as atypical hyperplasia or endometrial carcinoma, patients should be referred to appropriate management in gynecological oncology. While the guidelines give us clear thresholds for biopsy, hysteroscopy, or hormone adjustment, we always need to discuss these options with our patients. Shared decision making ensures that we balance safety with her quality of life. This algorithm allows clinicians to stratify risk effectively, ensuring the timely intervention when necessary while avoiding unnecessary invasive procedures in low-risk group. This slide summarizes the key situations in which endometrial biopsy should be performed. One of the main indication is endometrial thickness above the accepted thresholds. Another important indication is persistent bleeding lasting more than 6 months, particularly in women using continuous combined menopause hormone treatment. Biopsy should also be considered when bleeding recurs after a period of established amenorrhea. Additionally, indications should the presence of a focal lesion or imaging. Finally, women with significant risk factors for endometrial cancer should be investigated more proactively, even when imaging findings are borderline. In most cases, the first-line method for endometrial sampling is office-based biopsy using a pipal device, which is minimally invasive and widely available. While pipal biopsy is highly specific, its sensitivity may be reduced for focal lesions such as polyps or focal carcinoma, which is why persistent bleeding after negative biopsy should prompt hysteroscopic evaluation. However, if the biopsy results negative but bleeding persists, further evaluation is recommended with hysteroscopy and target sampling of suspicious areas. Ultimately, it is important to remember that histological evaluation remains the gold standard for diagnosis endometrial pathology. Once significant pathology has been excluded, and histological findings are benign, the clinical objective shifts towards optimizing treatment while maintaining menopause hormone treatment whenever it is oncologically safe. This is an important point because abnormal uterine bleeding alone should not automatically lead to discontinuation of treatment. Management strategies should therefore focus on individualized hormonal regimens, increase the risk of progestogens, switch the hormone therapy regimes to promote endometrial atrophy. And additional and a high effective option for endometrial protection is the levonorgestrel releasing intrauterine system. It provides excellent endometrial protection when systemic estrogen therapy is used, which is why many guidelines consider it one of the most effective options for women with bleeding on MHT. Overall, the key principle is to optimize the hormonal regime rather than discontinue therapy unnecessary. Now, let's discuss when it may be necessary to pause or to stop menopause hormone therapy. We should consider stopping therapy immediately if there is persistent unexplained bleeding despite evaluation, atypical endometrial hyperplasia, confirmed endometrial carcinoma, patient preferences. Urgent evaluation is required when endometrial thickness greater than 10 millimeter, rapid increasing bleeding, irregular heterogeneous endometrium on ultrasound, focal masses on imaging, systemic symptoms such as weight loss or anemia. Absolute are strong indication to stop the treatment. Also, are new diagnosis of estrogen dependent carcinoma conditions, venous thromboembolism or pulmonary embolism, a stroke or acute cardiovascular event, acute liver disease. And relative individual decisions are new onset migraine with aura, poorly controlled hypertension, high cardiovascular risk, and significant side effects, for example, mood changes. So finally, here are the key take-home messages from today's lecture. Bleeding during menopause hormone treatment is common and usually benign. Bleeding persists beyond 6 months of continuous combined menopause hormone regimes require investigation. Assessment should always include risk factors, treatment regimen, and ultrasound evaluation. Ultrasound should assess morphology and vascularity, not only thickness. Histological evaluation remains the gold standard when indicated. Rather than unnecessary discontinuing menopause hormone therapy, we should optimize therapy through shared decision making with our patients. Menopause hormone therapy management is dynamic. Continue when safe, modify when possible, and stop when necessary. Thank you for your attention. I look forward to discussion.
Thank you, Dr. Hasmik, for the exceptional talk. It was very clear, emphasizing key points and extremely helpful in our daily practice. Unfortunately, due to time restriction, I think I will be only able to ask one question, but the rest of them maybe you would kindly answer in the Q&A box. So maybe I can combine two. There are questions about this superiority of progesterone types, for example, micronized progesterone over dihydrogesterone, or using the vaginal micronized progesterone. And from an endocrinologist who is not able to do ultrasound or physical exam, how to manage these patients. Maybe you can combine the answers.
Okay. Thank you for your question. We in this case, we always use micronized progesterone because it's more safely than dydrogesterone or simple estrogens, synthetic estrogens. So micronized progesterone have low side effects and can help patients with postmenopause bleeding. But normally we use levonorgestrel. It has a high endometrium protecting effect than micronized progesterone. But we can have many cases when we can use intrauterine device. So we start with micronized progesterone and then continue with intrauterine device. So in endocrinological aspects is also micronized progesterone is more appropriate, approvable than synthetic one.
Thank
Okay.
you.
Shall we switch to the next presentation, maybe?
Of course.
Ipek, okay?
Yeah, of
Okay,
course.
Hasmukh, thank you very much.
Thank
Okay.
you.
And so then I would like to introduce now our final presentation before we then come to the discussion of the cases. So the next topic is sexual health in menopause. This topic is going to be presented by Dr. Leopoldo Santiago Sanabria, and he's an MD. He's from the Universidad Panamericana. He's specialized in obstetrics and gynecology, and he's from the National University of Mexico. So this, I think, is the reason why we have so many Mexican here in our audience today, all for you. And he's a fellowship, has a fellowship in gynecological oncology, and he's a professor and researcher at Pan American University. Okay, so Leopoldo, please start.
Thank you so much for the presentation, Professor Petra. I will share my screen. Okay. First of all, I want to thank the invitation to participate in this wonderful event. Thank you to AMAS, to the European Society of Endocrinology, ICE, ENTOC, and WATOC. I will be talking in these few minutes about a fascinating topic that we really know few about sexual health in menopause. I have no disclosure for my lecture, and let's begin. We must understand that menopause is a natural stage of life cycle in women's life. In the average here in Latin America is like 51 years, and it can occur earlier as a consequence of many things like diseases, cancer, surgery. So we must be attentive about this. And it will cause sexual problems that can go chronic, and it will have a negative impact in well-being and quality of life. I want to share the definition given by the World Health Organization that sexual health is a state of physical, emotional, mental, and social well-being related to sexuality, not merely the absence of dysfunction or infirmity. And it is recognized also as a basic human right. So, talking about sexual response in women is very complex. It includes many spheres like the psychological, biological, sociocultural, and relational. And it also has neuroemotional responses, pursuit of relational intimacy, and dramatic fluctuation of hormonal levels. And we must see this topic as a multidimensional thing that is more than the falling estrogenic levels, that it can be caused induced by any other causes, as I already said. It can be caused by chemotherapy or radiotherapy. There are also other gynecological disorders such as cancer or others like fibromyalgia, musculoskeletal factors, and other non-gynecological comorbidities like diabetes, cardiovascular disease that will repercute in women's life. And also we must not forget the psychosocial factors where the partner will be also involved. That's very important to say out. And also there are some barriers that begins with us as health professionals, that we also have erroneous beliefs and misconceptions. We have clinical histories that we don't collect all the data about sexual activity, and also we must not do assumptions, because we sometimes assume that the menopause women do not have a sexual life, and that's totally wrong. Also, discomfort when asking questions or fear of not being able to answer the question that the patient may have. Here, it is a diagram that I recommend for the assessment and the diagnosis. We must start with open-ended questions. We must have the time that the woman talk about their sexual life. Also, we must listen and respond all issues, all concerns and fears that our patient could have. And also, it is very important to take into account that we must listen or get involved the partner in this topic. We must have complete medical history. We must include sexual, gynecological, and obstetric history. Also, we must ask about the menopause status, the severity of symptoms that will repercute also in the quality of life. Sometimes only if it is indicated, we can ask clinical and laboratory examinations. And when it's possible, we must do our clinical examinations. This is a Latin American study, very interesting, that I was talking about assumptions. And I want to remark that women were asked how important was sex in their life. And we see that during menopause, it is really important, this matter, in almost like 60% of the women. So that's the importance of this topic that we must know and we must address in our consultation. Also, the International Society for the Study of Women's Health, Sexual Health, proposes a four-step model that is similar to the other diagram, that is disclosing and sharing the problems themselves in response to open-ended question, naming and framing the problems, active listening with empathy, and the assessment and treatment or referral to a specialist. Here are two questionnaires which I recommend. The first one is the FSFI, which is an old one that includes 19-item questionnaire accessing 6 areas. And this is the promise, which is mainly for oncology patients, which is a diagnostic tool addressing sexual function and satisfaction in oncology patients. Also, we have the genitourinary syndrome of menopause, which was already addressed in the last lectures. It affects 60 to 70% of postmenopausal women, and there is a estrogen deficiency that causes atrophy, urogenital atrophy, which will give us different symptoms such as irritation, burning, itching, and sexual pain, and other symptoms proper to menopause, which will be nocturia, incontinence, sensation of a lump in the vagina. So the GSM plus the menopausal symptoms will impact negative in the quality of life. So here is the most important, which is management, that is supported in 4 pillars. That is the psychosexual counseling, the non-pharmacological interventions, the pharmacological interventions, and the general and lifestyle interventions. Well, beginning with the psychosexual counseling, we have that it includes 2 big spheres, which is sex therapy and psychoeducation, which includes also cognitive and behavioral therapy and mindfulness. So we must not do any judgment. We must involve the partner-related problems, and we can support the woman to reflect, to have mindfulness, to reduce the self-criticism, which is the main goals, to reduce this distress for achieving the sexual satisfaction. Also, there is a non-pharmacological treatment, which includes lubricants that can be used with topical estrogens as well, dilators that prevent vaginal stenosis, mainly in patients who have received brachytherapy that I see a lot in my field. Hyaluronic acid, which is another option in those patients which have contraindications for hormonal therapy. Pelvic floor muscle training that will be very recommended for urogynecologists, that really improves the sexual function in women with GSM, and also the laser therapy that was already addressed and is effective and when tolerated for vulvodynia. I want to show this study, which is a systematic review, which concludes that it is effective. Laser therapy is effective, even the JAK or the CO2 therapy, but also shams therapy seems to be also effective. There was not a very significant difference between these different types of laser. Also, I like this pharmacological therapy diagram. We must know what is the problem and what are we gonna get for the treatment. So we must have this in mind, which is our patient's problem and which treatment we're gonna prescribe. So we have estrogens they may improve the sexual well-being, and we have various preparations. For vasomotor symptoms, we have the cysteamine administration, and for GSM, we would prefer the vaginal administration, and we also have the transdermal that will be favorable effects on sexual function. This study, the KIPS, that include more than 700 patients, they were 52 years in average, and there was no difference between groups about the symptoms that they referred. Mainly, they were moderated to mild, and we see here in these graphics that the transdermal administration was even higher, and there was a statistically significant difference between the oral and the transdermal in all sexual symptoms that were referred by the patients. Also, we have this meta-analysis, very interesting, with that which they compare placebo with no intervention and the different preparation of estrogens, and there was not a strong evidence that these preparations improve sexual function. Only estrogen alone, they show that there was a moderate quality of the evidence, and other preparations, the evidence showed that they were very, very low or low. Also, there is a question that there will be possible tachyphylaxis with transdermal therapy. In this paper, it was shown that there is not a significant, statistically significant difference, and there is no tachyphylaxis with this via of administration. So we have that transdermal estrogen therapy is being associated with favorable effects on sexual function compared to oral estrogens, but there is limited evidence to support that the effect of hormonal preparation on sexual function, and low doses of menopause hormonal therapy is safer, and tachyphylaxis only occurs in high doses, which does not occur in the transdermal administration. Also, we have progestogens. There is limited evidence about this, and it should be individualized to the patient. So we have, this is the biggest RCT and meta-analysis, which only include 10 studies, and there was no difference between the via of administration. It was a slighted, there was a slighted preference for levonorgestrel, and about concerning about the causes, it was shown that micronized progestogens were better even for cardiovascular risk or the risk of breast cancer. So we have that postmenopausal women with intact uterus will have to give progesitogens for the protection for hyperplastic effect on unopposed estrogens, but there is limited evidence, and there was a slightly better effect with levonorgestrel implants. Also, we must individualize concerning about cardiovascular risk, the risk of breast cancer, and taking into account other comorbidities such as diabetes mellitus, and we would prefer the micronized progesterone. That is the safer option. Also, we have Tibolone there is few evidence about this, but it's a good option that we can have, that it can improve sexual dysfunction in terms of vaginal dryness and sexual desire. We also have testosterone that can increase the sexual desire and the arousal. Also, it can be prescribed by transdermal route, but we must monitor this periodically. I want you to take this into account, that we must have a proper dosing about this, and the transdermal testosterone is the one that will be preferred, but it is needed a very few amount, only like 300 micrograms a day to achieve adequate levels. Also, we have the hydroepiandrosterone, which can be administered by via vaginal, that can improve vaginal atrophy in menopausal women, and the ospemifene, which is a third-generation selective estrogen receptor moderator that can help to GSM-related symptoms such as dyspareunia, and it can significantly improve vaginal tissue, and is also a safe option for breast cancer survivors. We have other non-hormonal preparations. There is limited evidence about this, the sildenafil, the bupropion, that can be an option in those patients we have that they have hyposexual disorders related to antidepressants, folic acid, oxytocin, vitamin D, that they need more RCTs to give a good recommendation, a good evidence about this. Also, we have recommendations about general and lifestyles, which are smoking cessation and reduce alcohol. We must promote regular aerobic and resistance physical exercise and communication with us and with the partner, and it will improve sexual health and well-being. So, in summary, and to conclude, the messages that I want you to take home is that we must break the barriers that they begin with us about talking about sexual health during menopause. Also, that the management, we have many kind of treatments, but we must individualize, and we must focus on the cause in order to give the best treatment as possible. So medical management and psychosexual counseling comes together. And also, it is important to involve and to hear the partner, because we sometimes forget about the partner and we only address the patients, but here it is a problem about two. So, and also, I would recommend that training on sexual health during menopause for us trainees should be included in our education, because sometimes we don't know how to address these problems. Also, to finish, I want you to take this quote, that is, addressing female sexual dysfunction requires a comprehensive, individualized, and empathetic approach that recognizes its multidimensional nature and prioritizes each woman's quality of life. Here are my contact details if there is any question. I want to thank again the organizing committee for inviting me, and I'm so glad to see many Mexicans and Latin American people hearing my lecture. Thank you so much.
Thank you, Leopoldo, very much for your great presentation. Very interesting and very important. I have a question. And is it difficult for you in your country to convince women and also their partner to have a sex therapy, to go to a sex therapist or psychotherapist?
Yes.
I find it very difficult to convince my patients to go somewhere.
I will say that in Mexico and even in Latin America, there is a big taboo about these topics. Even there is the fear beginning from the doctor that to address these topics. Sometimes we only take these problems apart. So to make this recommendation to even to the partner, I think is the hardest thing of all.
Okay, so you think we first need sexual therapy for the physician so that they are not have such a barrier, and then ask their patients to go and see a sex therapist?
I think yes, because here in our training programs we don't have like a menopause course, so we're not familiar to address these topics, not even sexual health. We became like shy asking about these questions. So I think it must begin first us, then the patient, and then the partner. And I think the hardest part is with the partners, because there is this culture in our countries that they don't want to talk about these topics.
I think it's not only in your country this way, so we can all learn, I guess. There's
Yes.
there's one more question, and then I will hand over to Ipek. So, since we don't have any approved medication for sexual function in postmenopause, what are your experiences regarding the use of supplements like arginine and citrulline?
Oh, there is no evidence about those recommendations in those treatments. I cannot do a recommendation about this, as there is no evidence. I
Okay.
think um, that we must prescribe more where is the evidence that is estrogens, progesterone, and testosterone. But even with those, there is little evidence. There is still little evidence.
Thank you very much. Okay, so now Ipek, it's your turn, and we
Thank you
come
so
to the
much.
cases. Thank you very much, Leopoldo.
Thank you, Dr. Leopoldo and Professor Petra. And now it's time for us to move into discussing real life challenges and learn from real experts in about urogynecology cases. Before introducing today's case presenters, I would also like to take a moment and introduce our moderators, who are representatives from ENTOG, WATOG, and ESE. Today we have Dr. Francesco Costantino, who is a representative of ESE. He is a medical doctor specialized in endocrinology and metabolic diseases, currently working as an endocrinologist at Bagiovara Civil Hospital, and a PhD candidate in clinical and experimental medicine at the University of Modena Reggio Emilia. He is actively involved in clinical and translational research and a member of multiple scientific societies, including ESE. We have Dr. May. Welcome, Dr. Francesco. And now we have Dr. May NG, who is a representative of ENTOG. Welcome, Dr. May. Dr. May is a specialist registrar in obstetrics and gynecology in Ireland, with a special interest in sexual medicine and vulvovaginal health. She is a member of the ENTOG Executive Committee, as well as European representative of WATOG. She also serves as chair of the Young Sexual Medicine Academy of the European Society for Sexual Medicine. So once again, we are happy to have you, Dr. May. And finally, we have Dr. Akeniniene Ubom, who is the president and representative of WATOG, and he is a lecturer in the Department of Obstetrics and Gynecology, Faculty Clinical Sciences, Pamo University of Medical Sciences, and honorary consultant and chief medical director in Nigeria. He is the president of WATOG, and he holds a Bachelor of Medicine, Bachelor of Surgery degree, and a Master of Science degree with distinction in physiology. Welcome, Dr. Akeniniene. We are happy to have you. And now I would like to welcome you all to this multidisciplinary platform, all the speakers too. And we will start with our first case. The presenter of our first case today is going to be Dr. Natalia Antic. She is a fourth-year internal medicine resident at the National Center for Infertility and Endocrinology of Gender Clinic for Endocrinology, Diabetes, and Metabolic Diseases, University Clinical Center of Serbia. The virtual stage is yours, Dr. Natalia.
Thank you, Ipek, very much. Dear professors, dear colleagues, I'm very happy to be here with you today, and I would like to congratulate the organizers for this amazing webinar. I really enjoyed and learned a lot yesterday and today as well. And thank you for the opportunity to present my case report of genitourinary syndrome in lactation. I hope that you can see my slides. So in our outpatient clinic, 12 weeks after delivery, came a 43-year-old woman with a body mass index of 28 kilograms per square meter. She was a non-smoker. In her family history, her mother's age of menopause was 46 and grandmother had type 2 diabetes. Before her one spontaneous pregnancy at the age of 43, she had diminished ovarian reserve, probably despite her age, and she was previously diagnosed with subclinical hypothyroidism. She was on therapy of L-thyroxine 50 micrograms per day. During her one spontaneous pregnancy, she was diagnosed with gestational diabetes. She didn't have any pharmaceutical therapies because she could manage her gestational diabetes with low-carb diet. She had polypectomy at the 40 years of age, and in her history, her menarche was at 11 years of age. Menstrual cycles were regular every 26 days. On the pain scale, level of pain was 5 out of 10. And as previously noted, she had one spontaneous pregnancy at the age of 43. She came actually to our outpatient clinic for regular checkup for her TSH levels 3 months after delivery. And during our examination, she complained to us about recurrent urinary tract infections. And that's how we managed to ask her a little bit more about her state and her complaints. We did the endocrinology evaluation regarding her diagnosis of gestational diabetes and also complaints about recurrent urinary tract infections. And we managed to find that she had repaired response to for glucose, and in her urine culture she had E. coli. The imaging results find that ultrasound of the pelvis was normal. In our outpatient clinic, we commonly use the questionnaires, and we do think that day-to-day impact vaginal aging questionnaire is a great objective tool for quantifying the symptoms of genitourinary syndrome in menopause, also in reproductive period as well as in menopause. And that's how we diagnose her with genitourinary syndrome in lactation. I'm waiting for poll now.
Yes, thank you, Dr. Natalia. Now I'm going to launch our poll. I hope that everyone can see. We're expecting your responses. We are very curious about your perspective. I would give 10 seconds more for you to answer. Okay.
Okay,
I'm
so
ending.
in our first line therapy, okay. Can we continue now, Ipek?
Yeah, of course. Go
Okay,
ahead.
great. So in our first line therapy, despite she was came to us 12 weeks after delivery, she was currently breastfeeding. We started giving her hyaluronic acid vaginally. Our patient was very concerned because she was lactating and had a baby boy. The therapy is going to be managed, or maybe come out or managed with a low dose estriol. And for our second treatment opinion, we would wait for some time, and after that, after lactation, we would advise her to start using metformin extended release in dosage 150 milligrams with low dosage vaginal estriol. In Serbia, we do have two components of low dose and ultra low dose of estriol. The first one that we spreadly use in our outpatient clinic is the combination of 0.03% of vaginal estriol in combination with lactobacillus. I do think that Professor Stute and Professor previously commented on this ultra low dosage of estriol. And the other treatment decision for us was, as previously mentioned, metformin low dosage of vaginal estriol. And for her short-term follow-up, we did after 4 weeks administrated of therapy, we gave her once again day-to-day impact of vaginal aging questionnaire. We successfully validated in Serbian language, so it was very easy for us to manage to see scoring before and after administrative therapy. And for long-term checkup, we did a checkup after 6 months with ultrasound of pelvis and also the menstrual calendar with the TSH levels. Thank you.
Thank you, Dr. Natalia, for this interesting case. We can now briefly kick off the discussion. I would like to invite all our moderators and speakers to share their thoughts on how they would manage this case. And I would like to share the results of our poll. So 43% of our audience preferred vaginal low-dose estrogen plus a probiotic therapy for recurrent urinary tract infections, and 28% preferred non-hormonal options. So who would like to start on discussing this case? Maybe Dr. May, how would you manage this patient?
Yeah, I suppose, thanks very much, Natalia, for this very interesting case. It's certainly very interesting because you told that you are in internal medicine to kind of encounter this case. I would actually, I feel like for me, in this case, there's this few different elements that's missing for me in a sense. I found it very interesting how she was referred to you guys because of her experience of recurrent urinary tract infection. Like, I'm curious, and I'm not sure because I had a little bit of a connection problem there when you were presenting on her symptoms. I wonder if she had any other symptoms that had led to that, because that wouldn't be a typical referral postnatally. Like, I wonder, does she have any vaginal dryness, dyspareunia? Did she have any other kind of urinary symptoms that prompted that prolapse, something like that as well? And whether did she also have recurrent UTIs out of pregnancy as well? Because that would kind of manage things differently. Could you clarify on that?
Okay, so she came to our outpatient clinic regarding her TSH levels because she was on L-thyroxine during her pregnancy and before that. So we were checking her for every 4 weeks during pregnancy and 12 weeks after her successful delivery, and also managing her gestational diabetes. During our examination, she complained to us about postpartum urinary infection And that's how we managed to find the complaints about recurrent urinary infections, because she couldn't manage or find out what was the case for that. We were actually, regarding her gestational diabetes and postpartum urinary infection, we suspected of probably maybe some metabolic disease or maybe something metabolic, because she was in the spread window after delivery. 3 months after the delivery, we could do oral glucose tolerance test, advising the latest recommendation regarding the gestational diabetes and tracking it after the delivery.
And do you know what type of delivery she had? For example, did she have instrumental delivery? Do we know if there's any pelvic floor trauma that has occurred?
No, we don't have anything.
So you don't know whether
regarding.
is it
No,
vaginal delivery or
no.
instrumental, anything like
Yes,
that?
it
Okay.
was vaginal. She didn't have a C-section.
Okay, but not sure whether is it with instrumental forceps or vacuum.
No,
Nothing.
it wasn't with instrumental or forceps.
It wasn't. Okay, yeah. I mean, the other thing then prompts me to mind as well is how long was she in pushing, stage 4? In some place, it might be that might be a crucial thing that affects her pelvic floor health itself. So I think those are the few things that I would explore when I face a patient like this, would be in the history taking itself. I don't know if anyone else would like to share on this part.
Thank you for your comments. Maybe from an endocrinological perspective, we can hear Dr. Francesco.
Yeah. Thanks, Natalia, for this interesting case. And I think that is really intriguing, the fact that you'd like to administer metformin to this patient, because the glucose tolerance test was nice after delivery. However, she had a gestational diabetes, so we know that she is at high risk of, developing diabetes and, over diabetes later in life. So I was wondering if you have any data about how things are going on this topic. I mean, is she fine? Is she having any problem like, prediabetes now or not?
Thank you, Francesco, very much. So we are checking her for every 6 months. She doesn't have any diabetes for now, but we are checking her up and treating her for that. She had a little bit impaired glucose response in her oral glucose tolerance test, and also we are closely monitoring her because of her family history and her mother. Her grandmother actually had type 2 diabetes, and despite the gestational diabetes.
Thank you. And Dr. Vakaniniene, how would you manage genitourinary syndrome of lactation as a general perspective?
All right. Thank you. It's a very interesting case. For me, I would just like to ask. I'm a bit concerned about the pharmacodynamics of combining metformin with estrogen. What concerns did you have, doctor?
If I understood it correctly, we don't have any concerns regarding usage of local estriol and metformin usage.
Because as you know, estrogen can interact with metformin to reduce its effectiveness in glycemic control. So, any worries? Or probably that is being avoided because you are using very low doses.
Yes, we use a very ultra low dose of estriol vaginally, not systematically, and there is no any interaction regarding the usage of metformin.
I think because it's vaginal estrogen, it's absorbed very little in the body anyway, so that there's very little interaction with metformin. Actually, another thing I was wanting to ask as well, Natalia, is she on any postnatal contraception? Because that might also affect her symptoms, I wonder.
No,
Mm,
no, no, she wasn't and she isn't.
mm, fair.
Thank you.
Um,
I will also agree on using vaginal estrogen won't be a big issue because of the low amount of in the blood. So who would like to
may I?
say a few comments from our speakers? Dr. Hasmik?
I think it is very real and common case for 43 years old postpartum period women and often under recognized, especially in postpartum women who are breastfeeding. And this is often misdiagnosed mostly as infections, for example, candidiasis or other urinary tract infections. And in this case, if cultures are negative and symptoms presents, in this case, we can think about genitourinary symptoms of lactation. I mean, when we have a breastfeeding women with dyspareunia, dryness, and negative infections, we can think about genitourinary syndromes of lactation and first line in this case vaginal moisturing or we can use lubricants during intercourse and early postpartum period, mostly first week. I know that we can't use any hormone. We need to manage her, preferably non-hormonal, and then shift to hormonal treatment.
Yes, thank you, Dr. Hasmik, very much. I was actually discussing these treatment options during your presentation with my mentor and boss. She is Professor Marina. She presented yesterday. I'm not sure if you managed to listen to her talk. And we were really discussing how it is important to manage the spread and very tight relationship between gynecologists and endocrinologists regarding this treatment of genitourinary syndrome.
And Professor Stute, do you want to wrap up this case, sharing your perspective?
Okay, to be honest, I was wondering if I have ever seen such a case because I've never worked in, I've always worked at university clinics and probably I've never seen any patients after delivery with symptoms like this. But as already was mentioned, I'm always very pragmatic. So if I had ruled out any other reasons for having these symptoms, I would have probably also given local estrogens a try and see if it works.
Mm-hmm. And Professor Erel, do you have any other suggestions?
No, I'm totally agree with Petra. And the pragmatic of view, I would give just local estrogen, and that's it, and see what happens. And if there is a recurrent urinary tract infection, so should be colonizing E. coli, and then the sensitivity antibiotic sensitivity test should be done, and there are some antibiotics can be given during lactation as well.
Okay, so I think we are on consensus on this case, so we can now move on to the next case. Thank you again, Dr. Natalia, for sharing your case with us today. And now I'm pleased to introduce our second case presenter, who is Dr. Raghav Bhargava, who is a PhD and a clinician scientist working in adult endocrinology, diabetes, and metabolism across North London hospitals. The stage is yours, Dr. Raghav.
you. Let me just pop it. Fantastic. Thank you for having me, and thank you for inviting me for this case presentation. So I'm going to present iatrogenic hypo/hypercortisolism due to a gynecological pharmacotherapy. And it's a pretty good case where it's a diagnostic dilemma and diagnostic challenge for the endocrinologist, but I think it's a treatment issue for the gynecologist. So there's a 33-year-old lady who's a management consultant of South Asian descent with normal weight, non-smoker, no recreational medication or any over-the-counter medication, no family history of any endocrinopathy or autoimmune diseases. She had a past medical history of breast fibroadenoma and migraine without aura, not requiring any medications. In her mid-20s, she had LASIK for cosmetic surgery for myopia, and she got married afterwards, and she was trying for a child. She had one spontaneous abortion at 6 weeks, which required surgical curettage. Now, when she was 33, she had dysfunctional uterine bleeding, and the gynecologist did a biopsy and found out that it's endometrial hyperplasia with atypia concerning for carcinoma. She was inserted with a levonorgestrel coil as well as started on medroxyprogesterone acetate at 400 milligrams once a day. So the reason why she came to the hospital was because of fatigue, some weight gain, and some clever doctor did a cortisol which was slightly low. On examination, she was normal for all the systems, so nothing on cardiovascular, respiratory, abdominal, neurological deficits. There was no salt craving, and there was no drop in her blood pressure, no postural symptoms. Laboratory testing, she had normal glucose, normal no anemia, normal liver, kidney, thyroid function, and calcium levels. Retrospectively looking back, she had a CT tap by which is thorax, abdomen, and pelvis by the gynecology team for this dysfunctional uterine bleeding, but the adrenals were not commented on, so it was neither big nor small. In hospital, she had a short synaptin or tetracycline test, which is a stimulation test. So her baseline serum cortisol was 6 nanomoles per liter, and then it rose to 81 and only 113 at 1 hour. And the normal pass using our assay at our hospital is 415. So she was definitely adrenal, not producing enough cortisol. And she was started on physiological hydrocortisone of 10 milligrams on waking, 5 milligrams in the afternoon, and 5 milligrams in the evening. Thereafter, the gynecology team increased her medroxyprogesterone further to 800 milligrams once a day. And then she came to the endocrinology clinic where she presented effectively with 20 kilograms weight gain over a couple of months, some proximal myopathy, and a buffalo hump or dorsocervical pad, all consistent with excess cortisol rather than adrenal insufficiency. Further endocrine testing revealed negative antibodies, so the primary adrenal insufficiency was ruled out, and a normal ACTH, which is, ruling out secondary and tertiary as well. Well, ruling out secondary, but could be tertiary. Her morning serum cortisol of hydrocortisone was just 8, so suggesting that there is some kind of insufficiency. But on the cortisol, when it was tested on the hydrocortisone, just to see if there's any absorption issue, it rose to 712, which is quite high at 9 a.m. Furthermore, she had suppressed DHEAS, SHBG, and adrenal and testosterone, suggesting suppressed adrenal function, steroid production, and she also had suppressed urinary cortisol and its intermediate metabolites, suggesting that this is a tertiary ACTH independent cause of Cushing syndrome. So now I think the question will come up as to what should be the next steps done for the audience.
Yes, I think the audience can now watch. Can you see the poll?
Yeah.
Okay, I will wait a few seconds. I'm going to end the poll in the next 5 seconds. Okay.
Thank you. And fine, yeah. So I can see basically refer for multidisciplinary endocrine gynecology management is what most people thought, which is basically what happened. Let me go to the next slide. So effectively, she was in the first line therapy as per the format of the slide is that she was kept on hydrocortisone, and the plan was to gradually reduce her medroxyprogesterone acetate. And as the audience decided that the joint decision was that she needs a hysterectomy because that's the source of the problem, and then wean slash stop the hydrocortisone and the progestins. So in the short term, she did end up having a subtotal hysterectomy with bilateral salpingo oophorectomy. They stopped the progesterone immediately, and the endocrinologist switched her to prednisolone 3 milligrams once a day. Only reason being that it's compliance cost as well as some metabolic benefits versus hydrocortisone 3 times a day. Long term, I mean, she was desirous of fertility, and that's what the main thing was, but now she doesn't have a womb anymore. And to repeat the Schwarzenegger test, so that we can get her off the oral prednisolone. So, I mean, the floor is open for discussion as to cessation of oral steroids. Now that she has premature ovarian insufficiency, how long or when and what should we start the hormone replacement therapy? And what the story started with fertility. Would it be I mean, she didn't have her eggs frozen, but could that be considered for its next case that the gynecologist see plus minus donation or just ending up with adoption? Yeah, thank you for having me. And there's some feedback if anyone wants to give. Thank you.
Thank you for this very complex case, and I would like to invite all our moderators and speakers to share their insights. Who would like to start? Maybe Dr. Francesco?
Oh, so thanks, Vargava, for sharing this such an interesting case. It's really challenging, and it remembers us that there are steroid compounds that are not considered like corticosteroids, but they have a corticosteroid effect. So it's really, really interesting. And the thing that I'm wondering now is if you have any data about how things developed after. I mean, did she normalize her her pituitary adrenal axis? I mean, because of these high dosages of medroxyprogesterone, and then after prednisolone, did she recover, or she's still taking prednisolone?
So the answer that after the surgery, after the hysterectomy, she stopped her progesterone. So that was effectively, as you said, a non-steroid drug causing glucocorticoid activity, which is exactly how the progesterone in mega doses causes this. Anything more than 200 milligrams, that's what the FDA as well as some case reports suggest causes glucocorticoid activity and basically exogenous Cushing syndrome. So that's the whole thing. To test her recovery, we need to get her off the prednisolone. She's on a 3 milligram dose, which is the physiological dose. And eventually we can either do a 9 a.m. cortisone and see how that is. Our cutoffs that we use as per the UK guidance is more than 300 nanomoles per liter, but it might be sensible just to do a Schwarzenegger or a stimulation test just to see if the adrenals have woken up, because she had this for a few months, this very high doses of progesterone. Yeah. Yeah.
Okay.
Go next. Raghav, thanks very much. It's really fascinating. I think one thing that really pops to mind is that I just found it curious, how is it that the patient is on both medroxyprogesterone as well as their levonorgestrel coil? Because according to the RCOG guidelines, the first line intervention for endometrial aplasia with atypia would be the levonorgestrel coil first, and then second line would be the oral progesterone. Like, how was that? What led to the doubling up of that? And was that actually discussed with endocrine, like the subsequent decision to increase the
I think you
medroxyprogesterone?
answered the question yourself. It wasn't discussed with endocrinology because the primary issue was gynecology. And as you mentioned, they did the coil first as per guidelines and then the oral progesterone. But I think it was just because she might have had pain plus minus bleeding and just to see if it helps. Because I think the suspicion was for carcinoma, so they didn't want to go and operate immediately if it could be stalled. That's what I would think that the gynecologist did. However, unfortunately, she did end up having her womb removed.
Mm.
Are there any comments?
Let me have a look.
I wanted to know, I wondered about reassessment of adrenal function afterwards.
So what we do is effectively there are three different kinds of steroids that most non-endocrinology doctors use. It's either hydrocortisone for whatever reason, prednisolone, and dexamethasone. These are the three common agents that people use who are not endocrinologists. Effectively, the best test is a 9 a.m. cortisol, which fits in with the circadian rhythm, and if it's above 300 nanomoles, as per the Roche assay, which is what we use, then there's unlikely to be any adrenal insufficiency. However, the testing has to be done at different periods of washing out these steroids. So hydrocortisone has the lowest or shortest duration of action, so 12 hours or more. So after the 5 milligrams in the evening, you can do the 9 a.m. test in the morning before the 10 milligrams. Prednisolone, we say a gap of 24 hours. So this lady is on a 3 milligram dose. So just take it, say, on a Tuesday morning. On Wednesday morning, you can have the test. And for dexamethasone, we wait 3 days for oral dexamethasone. But these are all if the tablets are in a physiological dose. So if a patient is taking 40 milligrams of prednisolone, say for asthma or COPD, there's no point testing because it's 8 times or 9 times the normal dose. So it's important to wean them down to 3 milligrams or 4 milligrams of prednisolone and then test.
Yes, I think it will be helpful for hypothalamo-pituitary axis suppression. Yes.
Yeah. And also the side effects of excess steroids. So no one wants that.
Great. Thank you.
Thank you.
That's a really interesting case.
Yeah, I agree. Very complex scenario. So,
Okay,
if
can I?
yeah,
Hello?
of course.
Oh, please, thank
Hello?
you. Go ahead. Yeah.
Okay. Yeah, so I just have a few concerns. The combination of medroxyprogesterone and levonorgestrel coil in the first instance. Why didn't you just use the coil only as first line? Why the combination?
I wouldn't be able to fully comment on that, but Dr. Ning commented that as per the gynecology guidelines, you are right, it's coil first, then tablets. But I think she was still having pain, bleeding, so they wanted to give both.
Okay. My other concern about prednisolone, you've addressed it, that it's low dose. So, okay. Very interesting case. Very
Thank you.
interesting case. Yeah.
Thank you.
I do wonder if, let's say, between the, like, I know that she has a little bit of bleeding, but did they, took another endometrial biopsy to actually see if it's still hyperplasia with atypia before they actually go on the medroxyprogesterone? So that's something that I would be curious to know about. I don't know if you know that.
I wouldn't. I'll have to check the notes, but I'm pretty sure they would have done a second biopsy. I'm certain. Yeah, it's difficult to say on this one.
And during the cessation of medroxyprogesterone, did the patient suffer any withdrawal syndrome, or did she, how can I say, had any concern or
So no, because you are right. Steroid withdrawal syndrome is a real thing, and she's on mega doses of medroxyprogesterone. That's why we put on we put on steroids just so that one, we're not happy with very low serum cortisol, and secondly, to prevent the steroid withdrawal syndrome.
Thank you to
Thank
all
you.
for this very rich and insightful discussion. Unfortunately, we need to move on due to our time restrictions.
Thank you.
And I would like to thank you all for the all case presenters, all moderators, all societies for being here. Before handing over to Professor Stute for the closing session, I would like to announce the best presentations from each day for presenting their impactful cases. For yesterday of day one, the best presentation goes to Dr. Aspasia Manta, who presented hyperandrogenism in menopause. And for today, the best presentation certificates will go to Dr. Vakhav Bhargava, who presented just now. Thank you for sharing your cases with us. Unfortunately, this is going to be the end. So before handing over to Professor Stute, I would like to thank you all again and also emphasize that this has been a fantastic start. So we should working on together and collaborate more, definitely. And for this organization of the event, I would like to thank the IMAS Early Career Working Group, Dr. Elena Armeni and Dr. Christina, who are also members, and also IMAS board and Professor Erel and Professor Stute for supporting us all the time and for their guidance. Professor Stute?
Okay, thank you very much, Ipek. It was a great pleasure to be with you during this webinar. And as we all see, the series has shown how important it is to work across societies, across levels of expertise, and also across teams. So this is why we placed such a strong focus on multidisciplinary approaches, because this is how menopause care should happen in practice. A very special thank to the IMAS Early Career Working Group, and especially to Dr. Elena Armeni, to Dr. Ipek Özçivit Erkan, and to Dr. Kristina Zaravinovska for leading this initiative and making it such a success. We are also very grateful to our partners, the European Society of Endocrinology, the European Network of Trainees in Obstetrics and Gynaecology, and the World Association of Trainees in OBGYN. Bringing all these perspectives together has shaped a truly meaningful program. So to continue this learning journey, we invite all of you to join IMAS Academy, which will take place on 3 and 4th of July 26 in Rotterdam, where we will build further on this case-based interactive approach to menopause care. And very importantly, we are working on getting you for less money to Rotterdam. So please check our IMAS homepage regularly and have a look on our social media account so that you will see what is possible for you. So thank you for all of you for being part of this journey. And we very much look forward to continuing the conversation with you. And thank you and goodbye and good evening.